We are excited to kick off our second session of the day, the Fostering Increased Inclusion session, chaired by Dr. Monica Willis-Parker and Dr. Laura Baker. We hope this will be an engaging session for you all, focusing on clinical research participation as a catalyst for improved cognitive health outcomes in diverse populations. If you're online, you can submit your questions via the Q&A box, or if you're in person, you can go to the mics on either side. And with that, I'd like to welcome to the stage our first speaker, Dr. Laura Baker. Dr. Laura Baker is a professor of internal medicine, neurology, and a public health sciences professor at Wake Forest University School of Medicine, an associate director of the Wake Forest ADRC, and co-lead of the center's OR, Core, and REC components. All right, Laura, you're up.
Thank you, Hannah, and welcome everyone. And thank you for coming to this session, where our goal was to have an open discussion and hopefully an honest conversation about what we can do to move the network forward in terms of fostering increased inclusion. And the way that we're going to address this in this session is in two ways. We're going to talk about how to foster increased inclusion how do we do this with our community partnerships, number one. And the idea here is that the ADRC research cannot work as a vacuum, that we have to have partnerships within the communities if we are going to have their buy-in, their participation, and meet their needs. And so I think we'll all agree, I think every one of us would agree, all ADRCs, that we have a lot of work to do there. We've got some significant changes that need to be made in order to engage our partnerships in a true and meaningful way. And then the second part of we have two presenters who are going to talk about their experiences, and I'll introduce them in just a moment. And then we have two presenters that are going to talk about their experiences on how to foster an increased inclusion environment within the house, within the ADRC. They are, as we all know, intimately connected. If we don't have an inclusive environment inside, we will not effect change on the outside in terms of inclusive environment. And if we only have an inclusive environment on the outside and not an inclusive environment on the inside, those outside efforts will fail. And so we cannot talk about one without talking about the other. So we have two presenters today to talk about their experiences in increasing an inclusive environment within the ADRC. And we've asked everybody, Monica and I have asked everyone to talk honestly, transparently. We are not here to just say what everyone's doing great. We're here to talk about how we can have real change as a network going forward. And so all the speakers have been asked to be very transparent and go ahead and give us their recommendations about what we need to, why are things the way they are, and what do we need to do to change. So that has been their charge. So just to get us started, just to set some context, when we're looking at, when we're talking about what does it mean to have an inclusive environment with our community partners, we're talking about how to develop a genuine collaboration. And we talk about that a lot. We think we can check boxes and say, yes, we got that. But if we were to ask your partners in the community, would they agree? And I think that's where our problem is, that we think we've checked the box, but we have not adequately engaged our community partners. And so some of the key ingredients, and these are just some ingredients, and you can find they're very similar to other ingredients you might find in many different other resources, is you've got to have community representation in the partnership. It's got to be real partnership, a real representation. We've got to be willing to share the power. If we're not willing to share the power, the community, why would the community partner want to really, truly be a partner with us? We've got to recognize and rely on our community strengths and our assets and highlight those. There's got to be some return for the community so that there's capacity building at the community level. It's got to be mutually beneficial. this partnership. And there's got to be funding available. And I don't mean funding for an event where you pay for their lunches. And I'm talking about true, deeper funding where you financially provide support for those true leaders in the community that are going to be visionaries to help us truly connect with the community in a genuine partnership. So I think this is where I hope we would take this conversation today, is how do we create a genuine collaboration and do it with intention, where we are actually willing to share the power. So the second component of our panel discussion, our session and our panel discussion will involve not inclusive on the outside, in the outside of the house, but how do we foster an inclusive environment inside the house. And again, we talk about this, we've been talking about it for years, and yet we still find ourselves with environments inside the ADRC that are not fully supportive of diversity, of equity, and of inclusion. So again, key ingredients, we all know these ingredients, but if any one of them is missing, our inclusive environment is no longer present. So we've got to have respect. Our individuals that we care for in our ADRCs have to feel respect. They have to feel a sense of belonging. They have to feel that they have access to opportunity, equitable rewards and recognition, appreciation of their individual attributes. There has to be cultural competence within the group. We have to have common purpose and meaningful work. That has to be felt, that every person in that community feels that we have a common purpose and meaningful work, and of high point is trust. And these are all boxes that we think we check all the time. But I think what I hope we'll talk about today is what violates these, what gets in the way. There is implicit bias at all points. There's racism at all points that interferes with any one of these that some may be unaware of. And I think any of these barriers continue to block our progress over time. So this is really setting the stage for our talk today, our session today, and I'm going to now introduce our speakers. I'm going to go ahead and introduce them all now and let them come up one at a time. I'm going to start with my co-lead here, Monica Willis-Parker. She's going to be our first speaker. Dr. Monica Willis-Parker is the medical director of the Emory Clinic of Social Circle. She is the director of both the OR Corps and Minority Engagement Corps of the Gonzweta ADRC of the Emory University. She is currently co-investigator for several NIH-funded projects. And she will be assisting me with the panel discussion. She will be our first speaker. Our second speaker is Dr. Gladys Maestra. She is the co-director of the South Texas ADRC, and she is the director of the Rio Grande Valley Alzheimer's Disease Minority Aging Research Program. Our third speaker, which is going to talk about fostering inclusion inside the house, inside the ADRCs, is Dr. David Johnson. He's going to be joining us virtually. Dr. David Johnson is the OR Corps leader of the UC Davis ADRC, and he is the director of the Recruitment and Retention Corps of the National Cooperative of Diverse Vascular Cognitive Impairment and Dementia, and the director of the California and Diabetes Prevention Program. And then our fourth speaker is Dr. Karen Lowe Graham. I just want to say she just was awarded her PhD on Saturday. So congratulations, Karen. So the little C on your agenda, you can just cross that off. She's not a C anymore. So Dr. Graham is the director of the Multicultural Community Outreach Program for the Rush ADRC. And so I am just so honored to have four fantastic speakers here with us today to share their stories. So Dr. Parker, would you like to start us off?
Good morning. And thank you to the OR Corps Steering Committee and everyone else for allowing me to be up here. I'm not new to OR Corps work, but I am new in my role. And the fact that I'm standing here in front of you is an illustration of inclusion. I'm a primary care doctor, and as you start thinking about who you need to recruit and who you need to encourage those among you, as Dr. Karlowicz, going back to something that Dr. Karlowicz said a little earlier, who are providing the medical care. I came to research courtesy of Dr. James Law and Alan Levy because I asked them how I could participate, and they made a way for me to do that. And a lot of the patients that I initially got into our research, they were my patients and friends and other people I could twist their arms to do research. And they have created a foundation of support for our ADRC that I'm very proud of. And physicians in your networks are very important to making sure that you get 100 patients who have MCI for your different projects, because you need somebody who can clinically classify them. So equity inclusion for engagement in research here. In 2008, I was awarded an NIH supplement award to study or help improve the enrollment of minority persons, African Americans in particular, in research at our center. So meaningful engagement is what we called it, and meaningful engagement for us was relationship building. The first relationship for all of us was physician to patient relationship. And that grew because I had patients. I said, well, you know, I'm trying to do this thing for research, and I need more people to get engaged in it. What do you think? And one of those partners was a bishop of an AME church, not a church, but like a whole district of churches. And he happened to be a classmate of my mother's many years ago when they were in college. My mother's 97 and lives with Alzheimer's. But long story short, is he said, you need to get into formalized organizations, and it is those patients and those social connections that made it possible for us to establish relationships with people in our community who would have an interest in what we were doing. So from that came what we call the Registry for Remembrance Community Coalition, which is built from relationships with not only faith-based organizations, but anybody who's creating and providing a service in communities of color. So this is our timeline. 2005, we started our ADRC, our Minority Engagement Supplement Award, 2008, 2010. Things I want to pay really close attention to. In 2013, I partnered with one of my partners to study biomarkers and compare African Americans to Caucasian Americans. These were our clinical patients. These weren't necessarily people we got off the street. And then in 2014, because we did so well, our ADRC committed to making sure that our UDS cohort contained at least 50% African Americans versus just European Americans. Keep in mind, we just were doing research initially on people who had the disease, but as our research has progressed, we're looking for healthier and healthier people. We've gotten money from different sources, governmental and philanthropic groups. In 2013, philanthropy made it possible for us to have assistance to help manage some of these social and community connections. And then we started working on a couple of other things. In 2017, we wrote a supplement award and got a separate funding for the Minority Engagement Corps. You can read the rest of this. In 2019, we were 33% of our UDS cohort, and right now I think we're 40, what was it? We're almost 40% of our UDS cohort is African American versus European American and other. We do conduct what I call an educational outreach. Why do we do this? Because the people we engaged with said, if you gave us a little bit more information, we might be able to help you a little bit more. If you told us what we needed to do, we might be able to help you a little bit more. And part of what they needed was not only an education about Alzheimer's, but it was also about aging and how you could get involved in research, because believe it or not, most people don't know how to get engaged in research. You would think that the doctor seeing them might be able to engage them in research, but you can't get in research if the doctors who see you don't know about your research, right? So that's where we started. So we started with a bunch of retired school teachers because that is who designed our educational outreach, and I say school teachers because they were school teachers. They are school teachers, and they still volunteer. And they wanted programs for the community, so we set up things with big, kind of like, I call it big, but large community presentations, I'm usually the person who goes to smaller groups of less than 50, and if they want more than 100, I don't roll out my subject matter experts for anybody less than a group of 100 people. So we've grown, we've been doing this a lot, and we did it in accordance with what our audience said that they wanted. So we talk about Alzheimer's, we talk about Alzheimer's research, we talk about aging, we talk about resources that are available in the community. We try to make sure that we address the needs of our audience, depending upon what it is they want. But more importantly, and this is a real key thing for our Alzheimer's Disease Research Center, there's not a single investigator that we work with who doesn't participate in these events. Dr. Law, Dr. Levy, Dr. Hales, Dr. Goldstein, anybody who's got an investigation that they want populated has a responsibility to come in front of the general public and tell them what they want. It's then the responsibility of the coordinators to try to follow it up. But transparency and accountability come from showing your face in the community. So whether that's in your big forums on your campus or in a little church or in a community group, that's what you need to do. You don't need to send a coordinator. That's just me. Educational programming, in the pandemic, we had to pivot a little bit. We did not have as many in-person programs as we normally do. So since March of 2020, every week since then, we have conducted an online webinar called Brain Talk Live. We engage providers and investigators from around the country. Some people in this room have participated. They also participate in our Brain Health Forum. None of our programs locally last more than 90 minutes. Our webinar each week is just an hour, just an hour. So this is an example. Last week we had a doctoral talk about falls and prevention, risk prevention of falls for older adults and people with and without dementia, and he's from Georgia State University. If you go to our YouTube website, we're really proud of it. You can see all the different people who've participated in us. Before and after most of our events, we hold what I call a research recruitment fair, which means before any of our educational programs take place, we generally have the studies that are recruiting exhibiting in the waiting room. And we kind of make people go around to talk to the different coordinators, find out what's involved, take a flyer, learn something more, sign something. We do this also after a major event. After we've had several, we do what we call a research social, where people who've completed a research interest form are encouraged to come and ask questions, and we try to expedite their sign up into different things. The success of what we've done, these are a little dated, but we haven't gotten everything quite up to par to reflect 2023. But you will see that from 2004 to 2008, this is the number of participants, depending upon their demographic, and how we've progressed. You see that we now have a little bit more equitable participation of people of color. We still lag behind when it comes to minority men, but we lag behind with white men too. So things that are important, these are important implications and milestones for us. Our center funding in 2025 was granted with African American recruitment as the emphasis for key roles of our Minority Engagement Corps. Our ADRC made a commitment to making sure that our UDS cohort would be at least 50% African American. That's still a goal. Our autopsy rates for UDS participants versus the African American versus European Americans are pretty much similar. Our African American UDS cohort participants and other study participants are contributing not just to one study, but more than one study. We are collaborating with several different centers across the country for our biomarkers. You can read all of that. But more importantly, we have maintained a consistent trust, consistent visibility, and dedication to serving the needs of the people in our community. And it's not just educational programming. We have to reassure them that if there is something wrong, we're going to help them, assist them with getting access to the right health care provider, whether that's in the Emory healthcare system or somebody else's system. We have a lot of people that trust us simply because many of them are our patients. They believe a lot in our institution. And these are some of our participants, and all of those people that you see there have been committed to our research. Bishop Adams is the gentleman on the left. He's now deceased, but He supported our program, continues to do so. So our aims for our Minority Engagement Corps, you can read. This is something that gave us dedicated funded personnel to do the minority outreach. And these are some statistics from our Brain Talk Live. Each week we have over 200 people who participate in our webinars and ask us questions live. This is an example of our geographic distribution. Brain Talk Live covers the larger metropolitan area, but not only do we get the metropolitan area in Atlanta, we are an international webinar, so we're all really excited about that. So in summary, it's important that you have a dedicated recruitment team, you fund that recruitment team, and you have to make a legitimate effort to do so. It takes dedicated personnel. Establishing collaborative relationships with organized community groups serving your targeted community. That's not just faith groups, it's sororities, it's other service-based organizations, area administration on aging. It's also professional groups, physicians. The physicians who populate our webinars, we now have a minority engagement, minority men's discussion group once a month. And of course, the minority men want to hear from other men. They will tolerate women only if they're facilitating the discussions, which is what I do, so I get tolerated. I'm either their wife or their doctor, something like that. That's why I get to stay in the room. But there are community providers, urologists, gastroenterologists, surgeons who come and help us with our recruitment and they buy into our research efforts. So community outreach doesn't need to focus just on Alzheimer's. You need to talk about healthy aging. You need to talk about healthy healthcare access, how things can be done, what services are available. You have to do basic things like help people understand their Medicare, what Medicare pays for, what Medicare doesn't pay for, and how, why. Well, I'm a primary care doctor, and I see research as a way to better improve the health care that everybody receives. I've got 4 seconds, so I'm going to sit down. Thank you.
Thank you, Monica. Dr. Maestra.
Buenos días. Good morning. Thank you. That was amazing. I cannot see my slides over the time. I can see it now. So thank you. It is a real pleasure, and I want to thank the committee, but particularly Laura Baker, for inviting me. And I have to disclose, of course, I received the funding from NIH, also from the Texas Alzheimer's Research and Care Consortium. I have a small nonprofit that I'm bound to disclose of a potential conflict of interest, and I have to remark that my views are mine and do not reflect those of my employer or funders. And I'm gonna share with you what I think might be most useful. I have to clarify the concepts and using meaningful, then I'll talk about my interpretation of meaningful engagement. I'm going to expand on multiculturalism, how we document change, not for reporting, but for how to document change to influence our actions in the Corps. Share with you a little bit about our experience in Texas. We've been an ADRC center for 18 months, and I'm so grateful to my director, Dr. Sura Seshadri, and to all of you that help us to get there and provide a quick summary. So among the concepts, I just took the title, trying to understand what was expected from me. And best practices, what are the best practices and set of guidelines that represent the most efficient or prudent course of action in a given situation? So I'm not gonna prescribe what are the best actions because I can only talk about what we are finding out about our best practices. Establishing is to build, and this was, what we are doing now, genuine. And I, like Laura's recommendation of being honest, genuine it is to be real and exactly what it appears to be, no pretending. Community partnerships, supportive relationships. Engage, of course, to participate or become involved. Underserved groups, I'm not thinking about racial and ethnic minorities alone. It's those groups that do not receive the attention, care, or services they need. And the concept that I use in the community about ADRD research, and I share that with the previous speaker, the research is a mean to mitigate, to decrease or eliminate the burden of Alzheimer's disease. The purpose is not just to engage. The purpose is that we work together to mitigate the burden of this disease. Meaningful engagement, there are several models, and we benefited all this year from our interactions and collaborations with UC Davis, and one of it is with Dr. Sergio Aguilar Gaxiola, and he and his team put together a set of documents, wonderful, and metrics about what is a meaningful engagement. And it has, this model provides 4 different domains. And we've been focusing on building 2 specific domains. It's the partnerships and the expanded knowledge. The partnerships, of course, has to do with diversity, inclusivity, mutual value, trust, and what can we build in the structure of the center in order to provide all these elements that we want. And the expanded knowledge, 3 different domains, which include the creating new curricula, strategies, tool, the bi-directional learning, which is very, very important, and the produce community-ready information. One aspect that we encounter everywhere, but I think in South Texas is critical, it's the shift in the mindset from a monocultural to intercultural mindset. And we've been working with the ADRC RECMAR that we also have in the University of Texas, Rio Grande Valley, and what we talk about cultural agility and the trainings and that we do for all our staff, investigators, our scholars, and our partners. So multicultural older adults belong to multiple worlds and carry those worlds with them. But I think when I talk about this, I think about myself, not as a Latina, but as a researcher, for example, and as a caregiver, for example, 2 different worlds that we know where to put our hats when we need to behave like a researcher and when we need to behave as a caregiver. And multicultural individuals are those who identify themselves with 2 or more cultures. But this is necessary, they have internalized associated cultural schemas. But not all identities are internalized. When individuals internalize the cultural identity, they internalize the associated set of knowledge, beliefs, values, norms. But there is something called oppressed identity, meaning people, for example, I encounter say, well, I'm a 2nd generation or 3rd or 4th, I don't know anything about Mexico or Latin America, and I don't know Spanish, I'm just here and I don't know anything, and I've never been even in a taco place. And when we think about how to model this, let me see if I can, okay. So here, in the top and to the right, you see 2 different ways of integrating identities and integrating the plurality. So that's when we know, as researchers, that we know what is it to be a caregiver, for example, and we can shift. And so the psychological load is less. And but when you see that you don't have the opportunity to share, to be that, or that one culture has more value, for example, in the prioritizing to the left, then the other culture, it's minimized, so we have less access to the social capital that culture might bring. So we have made a point on how to get there on both sides, how to leverage that different cultures inside our team and in our partnerships. One way that we, as I mentioned, we made a big point on documenting change in all these aspects. And we use a documentation system portal that was created at Kansas University. Many of you may know. It's a community toolbox tool, which is amazing, and has a model of change. And this model, the solidarity model, basically says that you cannot just change at once. That is developmental. You have to do things to start the change, then to produce the change, actually, and then that's when you have the actual change implemented. For example, we document engagement activities in research facilitation, trainings, in different sets of partnerships. We document activities as actually dissemination as part of community actions. And we get this kind of metrics to see, what are we really doing. And in our actions, basically, at least we provide training for the community. Around 30% of our activities are directed towards that. And the different type of support we provide to the partnership and that they provide to us, like reviewing all our pilots, the abstracts are presented and reviewed by community members. This is the curriculum that we implement, and the community partners, each community partner select what they want to be sharing their growth with us. And so with each of our partners in the coalition, that we have now 23 partners, we go through different type of trainings, trying to see how can we increase minorities' participation, and of course, how can we best implement our processes. In Texas, one strategy that I have to mention first is that the RECMAR allows us to train 14 individuals, as you'll see here. Some of them transition to be, as you see here, highlighted in red, REC scholars for the ADRC, and now they are going back to the RECMAR, hopefully, as core co-leaders in the new cycle of the RECMAR. We have focused on understanding the social roles in the Hispanic family, and particularly familism, putativism, fatalism, machism, and other type of isms that we have to engage with and incorporate in our strategy so we are aligned in terms of values. We do a lot of community engagement and outreach activities, and we basically do focus group. I have to say, at least every month, we hold conversations basically every week with our communities, all different type of trainings. One in particular I want to highlight is the community health workers or promotora programs, where we have trained more than 400 individuals. We produce materials in English and Spanish, and we give that to the community and with even the policymakers in the city. And of course, we try to convey what is it to live in South Texas, and the different ongoing dissemination activities. And the end point of community engagement really is to mitigate the Alzheimer's disease and related the burden. And research is one mechanism, sorry about the misspelling. Community change requires academic community partnership through supportive and authentic relationships, valuing multiculturalism, decrease the psychological toll of everybody, and increase the social capital. And we say, seamos amigos, let's be friends, let's leverage our strengths and accelerate discoveries. So this is the wonderful team. I'm running out of time, but it's an amazing privilege to work with them, and I appreciate very much the opportunity to share that we have a very friendly team available if any of you want to reach out. Thank you very much. Gracias.
Thank you, Dr. Maestra. And congratulations on making such great progress in only 18 months in your community. Thank you. Our next speaker is Dr. David Johnson from the UC Davis ADRC.
Great. Thank you to the panel for allowing me to present here today, especially virtually. I appreciate your accommodation. This is an issue that I have found to be transformative in my own personal life as well as professionally. If we are in my to sort of just frame this for just a moment, I was asked to talk about equity and inclusion within the ADRC framework, and I think that within any discussion about race and equity, gender, sexual orientation, the milestone of George Floyd's murder in a public forum, and the political unrest and the protest that happened is a really incredibly significant milestone, and reframed the discussion about race in America in a meaningful way, perhaps. And I'll come back to the perhaps by the end of this talk, hopefully. At this time, of course, we were all in shelter in place, and the ADRCs were only in a virtual format. My studies and my staff with the ADRC, the staff for the Dementia and Diabetes Prevention Program, my staff for the Good Life, which was an online virtual social support network during the shelter in place time, were almost entirely African American and Latino. And when the murder happened, I, as most white Americans, especially white male Americans, were continuing on with work. And it was just a matter of a few days, but I started to realize an immense or seismic level change within the staff. And they were extremely traumatized by this. And that it was quite honestly a little surprising, because it was at the moment in which it occurred, it seemed as the events were unfolding, it seemed like yet another tragedy, yet another example of police brutality and systemic racism. However, the forum in which the news was delivered, the way the political climate, the anxiety that was in all of us due to being socially isolated, was triggering the past racial traumas of most of my staff. We, with the help of leadership, we formed, let's see if I need to do this. Yes. We formed what was a discussion group about what did this murder mean, and what we needed to do for our identity as an ADRC committed to community engagement, and what were we doing about this? How were we going to make a positive change within the staff and the relational structure of the Alzheimer's Disease Research Center, the associated research programs, staff and faculty, and really try to understand and discuss the role of race in our working lives. And we were charged with, to do this, we had to do this online, of course. It was a virtual group. We really met once a week. I think it then trickled down to 2 times a week after. But we worked assiduously between that June summer and into the fall to create a report that we're very proud of, and I've shared it with the discussion leaders here, and hopefully, if anyone wants it, I'm happy to send it. We have sent it out to everyone once before through the Nina and other members of the central leadership teams. But a report talking about specific identifying particular gaps in equity and inclusion, and talking about what the staff thought were actionable steps. And so I had the privilege, I'm a clinical psychologist by training, so some of those skills were coming in handy during these meetings. And I had the privilege to listen to this in profound discussion among the staff. And this is a meeting group that was anywhere between a dozen and 25 people at different times throughout this whole entire summer. And people attended religiously, and leadership made time where this was something that was part of the workday. So we were able to come together in a regular fashion, discuss these issues in privacy. No one was ever identified, other than at the top of the report, there was a list of all the members who chose to be listed as contributors to the report. And I'll say that I'm going to present some quotes from that report, that some are direct quotes and some are my summary of what could have been an hour and a half long conversation. But I think that these are the germinative issues that were at hand throughout that summer. And they're really, to come back, they're really the milestone. These issues are manifest in, I believe, all of our Alzheimer's disease research centers, in the vast majority of the working world within America today. So just briefly, we talked and developed meaningful themes. This is how we met, by teams. It was a private team. No one had to come. There was no expectation. And we created that report in short order. It was an intensive summer. So these are just some of the quotes that I'm going to set up or frame our discussion today with. My supervisor was insensitive due to naivete. This is my introduction here, about the trauma of systematic racial violence against all people. Supervisors need more training to learn to be aware about how the news and personal events affect the workforce. And this was exactly the thing I was talking about for myself personally, where I kind of went into this blindly because of my own white privilege, my own naivete of how significant, how triggering George Floyd's murder, Fiona, that summer just was hugely traumatic for most Black and brown people in America. And white Americans largely didn't get it until very late in the process, until the protests really started to drive these issues home. Nervous laughter when talking about LGBTQIA signals a lack of acceptance and potential hostility in the workplace. Words and actions carry weight, and sensitivity training is really needed, especially about microaggressions. Microaggressions were a theme that came up over and over and over again. Things that you don't intend to necessarily be aggressive, but shows a lack of understanding, and as a result, a lack of care to understand. Or things that make you nervous that you don't like, that you know are socially inappropriate, that you're inhibiting or trying to inhibit, but it's slipping out like the mercury. And sensitivity training and microaggressions, once you become aware of these things, you start to gain more control over them, but nowhere near enough of the staff have that kind of training, other than a fairly superficial online training, which is now pretty much wallpapered on all of our city trainings every year. When a Black woman points out the details of some injustice that has been experienced or perceived, then she herself is perceived as petty and angry. Black women are held to different standards in the workplace. Even though you are well trained, White management presumes you are ill-trained or even incompetent. And when you assert yourself, you're told to watch your tone. Well-educated people do not respect the limits of their expertise and make overreaching pronouncements about race and medical treatments that are clearly false. And when pointed out, they often get defensive. The use of doctor in public spaces for women of color who are doctors is not used in public spaces for women of color who are doctors. They're too often called by their first name only, and signaling inherent or subversive power differentials was the insinuation of this topic. So, I wanted to sort of come together here at the end and present the last few slides. Institutional racism exists in all forms, in all centers, I dare say. I know that it does at UC Davis. I know that it does in the ADRC. This is examples of that I was just talking about. Active racism, especially anti-Blackness, is on the rise everywhere. And when people are socially naive today, it has this undertone of being at least perceived, if not true, to be actively racist. In other words, if you're not trying to work on this issue on yourself and in your group, you are participating in an active climate of making a racist workforce and hostile workplace. Racism is a process that's sustained over hundreds of years and is simply not going to be erased quickly by the findings of one committee, as we're all seeing. Let me just say that the staff engagement is really driven by people who work at ADRCs, who work in a research program, especially those people of color, are motivated by the community engagement. And this is something that we need to think about, and it's probably, it is a way in to a more healthy, robust discussion. I'll just say that in closing, one of our main desires as a group was to have outside consultants come in with fresh, unbiased eyes and provide a safe space. Although we submitted our report in January 2021, as of today, there's been no outside consultant ever hired. And this is based partially on COVID limits, but those aren't true today. And it's very expensive. And we just don't have the money to bring in someone to work 2 or 3 days with a very large staff on these issues. It has been prohibitively expensive. But this is also just part of where we just come back to what has really changed since George Floyd. There is a great disaffection in the Black community and Latino community that while white America was engaged in a discussion about race for a brief period of time, they've lost their appetite to continue this. And we see this in our own workplaces, for example, where DEI is a service that is almost dumped upon the faculty of color. And it is a burden that is never ending for faculty of color. And I tell you that it is the white middle management and leaders that need to do this work more than having the DEI initiatives for preaching to the choir. I have a lot more notes in my slides. I encourage you all to say it, but thank you for your time, and sorry I've gone over slightly.
Thank you, David. And our last speaker is Dr. Graham.
Hello, my name is Karen Graham. I'm the manager of community engagement at the Rush Alzheimer's Disease Center. and I'm also co-chair of the Diversity Committee, along with my colleague Veronica Hernandez, who helped me to create this PowerPoint. In my presentation, I'm going to talk about three things. I'll discuss our long-standing commitment to diversity at the RADC, the different kinds of programming that we've had, and how that programming has made a difference not only inside of our center, but also outside in the community. So in about 2005, my colleague, who's now retired, Mary Futrell, suggested that we have a Black History Month luncheon. And with the support of Dr. David Bennett, our director, we actually had it. And it was very successful, well regarded. But I wanted to be more inclusive of the entire RADC. And I also wanted to provide ways to help educate our faculty and staff about DEI issues. So the first thing we did was we created Inside Highlights, and that's an opportunity for our faculty to talk to us about their recent research, and then we can share that information out in the community. We also had CPCs, clinical pathological conferences, where, especially for our staff, to learn about the history of a person, starting from being a very healthy person to all the way to the point that they died, then doing a brain autopsy, and with the results that we've received. And then we've had international potlucks now. We're doing international restaurant events where we just have fun and get a chance to interact with each other on a more informal basis. And then finally, this year, we started to have a community partner highlight where we have some of our community partners come and talk to us about the work that they're doing and how we've helped to collaborate. Our events occur 4 times a year. We have a Black History Month event in February, in May, Asian American History Month, and in the summer we do an international potluck. And between September 15th and October 15th, we have Hispanic Heritage Month celebration. So for our Inside Highlights, our faculty are, we have the newest faculty, like Dr. Poole and Dr. Agarwal. We have some of our core leaders or other core leaders, like Dr. Capano from Statistics, one of our newest core leaders, I'm so proud, Dr. Brian James, Dr. Crystal Glover is our core leader, and Dr. Marquez, Latino core leader, all spoke. And we also have the support of our executive team members. Dr. Lisa Barnes has given a couple of Inside Highlights, and Dr. David Bennett, our director, has also spoken for Inside Highlights. I have to tell you a story. So about 10 or 12 years ago, Dr. Julie Schneider did a CPC for us, and she brought the brain of one of our participants. And she and her staff, the way they treated the brain was so respectful, and she did it in such care. It still stays with me, and I share that information with our participants or potential participants who want to agree or who are considering organ donation. I want to tell them that this is how we will treat you, not only while you're alive, but even after you've died. So during the summer, we have a fun event, our international potluck. We have icebreakers, we have games, we have prizes, and we always have really, really good food. This year, we started with having community partner highlights, and our first speaker was Dr. Cynthia Tucker. She's a senior vice president of the AIDS Foundation of Chicago. We started a collaboration with her when we had a grant called the Center of Excellence in Disparities in HIV and Aging. And even though that grant has ended a few years ago, we still continue to have the relationship. We continue to partner with her and her organization, and collaborate in as many ways as we possibly can. So you may ask, why are these programs important? Well, for the first reason is because we want to help to make sure our staff are educated about the research that we're doing. You may be surprised to know, even our research assistants are asked about our research. Our research assistants go into participants' homes and do their annual testing, and our participants ask them questions like, So what are the new things that you're learning? I saw one of your faculty members speak on TV today. So what does that mean? So we try to make sure that our staff are informed about the latest research. Another reason we think it's important is because we get a chance to be able to interact with each other, not just in our own silo. We get a chance to talk. We talk to each other about some of the things that we're currently experiencing at work, but also our families. We get a chance to meet people who are different from ourselves. So I live in Chicago. I was born and raised in Chicago. Chicago is still one of the most segregated cities in the country. And the opportunity to be able to interact with people from all over the world has been mind-blowing for me. It has expanded my knowledge of all kinds of things, the foods that we eat, the experiences of travel, all of that has made a big difference. And it also has opened up doors for us. When we're trying to reach out to other communities, our faculty and staff have been one of the main ways that they help to open up the doors to some of those communities. That's made a difference. The food is always excellent. The food is always a glue. People always come out for food, so we always have really wonderful food. But I think the most important thing is that our administration has shown the support of diversity, equity, and inclusion. They've shown the diversity of our faculty as well as some of our staff, and that has actually reverberated in our efforts when we go out into those underserved communities to talk about our research and to show that we have faculty members and PIs who look just like them. So this is our diversity committee. It's very large and consists of faculty members, managers, and staff. And I want to say thank you so much.
Thank you, Dr. Graham. What we're going to do next is we're going to turn and have a kind of a shift, and we're going to move to a panel discussion. And the way this is going to work is we have some questions for the panelists, hopefully some provocative questions, and then we'll open up questions to the audience. We have about 25 minutes to do this. So I'd like to, if it's okay, Monica, if I could open up with one question. It's actually one that you inspired from the beginning. And that is, if I could ask all panelists, David, you are here with us, most certainly. And you speak from whatever perspective you'd like, whether you're talking about fostering inclusion inside the institution or in the community. But in an honest and open way, can each of you speak to why is progress so slow? Why are we talking? It's 2023, we're having these conversations. We've been having these conversations for 20 years, more than 20 years. But we intentionally for 20 years. Why are we still in the same place? Are we in the same place, and why? Who'd like to start?
I guess I can start. I think you really have to have a commitment to what you're doing. Somebody said, documenting progress. I think Dr. Maestri said that. I think that in the Alzheimer's Disease Research Center space, I think that I like to use the term diversity, equity, and inclusion is now hot. In our ADRC, it's always been important. It may not have been as well regarded in some circles, but it's always been important. And it's nice that everybody else is getting the same message. But I sit on review committees, steering committees, and when you partner with minority institutions or minority investigators, they're still getting the short end of the stick. They're not getting the funding. They're not getting the support. And, we talk about diversity in training. I mean, I alluded to doctors in training because I come to this as a primary care physician. And I think I was mentored into this before it became popular. But I think that you have a number of people who are interested in research who are going to be providers, consistent with what Dr. Karlowish said in terms of where we're going. You have opportunities available. It just takes a little work. And I don't know that even though we're committed in theory to change, the work of change has to go with it.
Okay.
Funding in particular.
I want to also mention that we have a lack of diversity of faculty. I remember for 18 years, Dr. Lisa Barnes was the only Black faculty member at our center. We now have 2 more, but that actually makes a difference going out in the community. When people see her, they want to participate, they want to help her in any way that they can, and join her studies. It makes a difference. Having Dr. Marquez as the Latino core leader and him going out in the community, people want to support him, but we don't have enough faculty members, and we also don't have enough staff. For us at the RADC, we have 1.5 staff members in ORCOR.
Thank you. I think that reflecting on those comments, I would add the issue of power. Still is very much, and we don't know how to talk about it. But being underfunded in our ability to generate community change, it feels overwhelming many times. I've been asked, like by other researchers from other centers, telling me, do you think you need to do that in person? And I say, well, it's like having a relationship with my husband. I want it to be in person. I need to be updated. I need to be responsive. I need to be supportive. And how do you do that? I mean, don't you have other things to do that, and yes, but so embedding that, it feels many times that you go against the current, that is not very well perceived, very well received, that is not as high as doing, some statistical analysis, for example. So I think still there is the perception, at least the perception, and I feel it real, the power difference in doing community work, community change versus other type of research.
And the comments that you just recited there about how do you do this and why would you do this in person conveys something else, doesn't it? What's the priority? Is this person in the community equally important to what you have to do on your schedule today? And I think that is where is a common problem, that it is, we say they are equally important, but we don't treat them as if they are.
And we don't feel it.
Yeah, and we don't feel it, yes. David?
I would say that there's really 2 ADRCs at the time. There's the one that's operating at the level of the ORCORs and community engagement and the RECs and trying to be relevant within that social networking space. And then there is power brokering, and that we need to have, the reason why I believe that we haven't made any progress is we haven't included those power brokers in that discussion. It's something that's a responsibility of other people, and it's not. It's the science itself is biased. It has these baked in implicit biases, and the white privilege, but also the academic privilege. This institution of academia is almost 800 years and running, and the hierarchies that are in place are so reified, and the personas we take and the chasm, really social chasm between those who hold the power of the PhDs, the MDs, the science, holy person science cast, and the staff is huge. And that needs to be broken down and become more of a human interaction. And I love what Dr. Maestre says. It needs to have that insinuated intimacy of understanding one another at a level that just doesn't exist right now.
And David, you and Dr. Maestre said this, shared power as well. Some sharing of the power so that all people feel equal at the table, or at least all people have a voice at the table. Is that in your experience as well? Yeah.
Absolutely. I mean, within the community action boards that we're involved in, all of our work is going and to them to have discussion, and in some cases, in the dementia and diabetes prevention program, they vet and make critical decisions on how we're going to implement the science in I think a meaningful way. Without that, they smell the BS. I mean, these people have been traumatized by racial injustices their whole entire lives, and the one thing they can do is they can detect the BS. If you're not fully authentic, I mean, it's just it's superficial at best.
Okay, thank you, David. Everyone who spoke this morning talked about, in one way or another, the leadership that was taken on, assumed, or needed to make change. And Karen, you talked about the leadership that occurs either through Dr. Barnes or through all the events within your center. That is a critical element. Dr. Maestra, you talked about how leadership, you had several examples of leadership and how there was someone in charge to make sure that the agenda was followed, that there was make sure that there was a focus was on inclusion and equity. David, that was clear in your talk as well. And Monica, you have many examples of where you have assumed leadership. I just want to ask the question of each of you. It seems to me in discussions with many of you that one missing ingredient is true leadership. And it's not necessarily not having the right person, but maybe not the right person with sufficient power to do what he or she is being asked to do. So let me just kind of frame that. There's two different ways. There's lots of different leaderships, models. So maybe we could talk both about inside the institution and outside the institution. So outside the institution, who is your community liaison? Has this person been empowered with ability to make the decisions, or are their hands tied? How do you find this leader? Is it, have we checked a box and this person represents the community of color that you would like to recruit, but this person has no training at all? Can you just kind of, let's maybe start there. What's the critical ingredients for leadership in the community to create an inclusive environment, and how do you make that happen?
So I think that one concept is readiness. Readiness for what? Readiness to participate, readiness to engage, and readiness to decrease the burden of the disease in the community. So we can increase the readiness to engage with the community and to engage the academic community partnerships. We needed to do that right away. We were fortunate to be in a new center. So we didn't have a history of not doing or doing. We just had the opportunity to implement a process of coalition. So we started with increasing the interest and readiness of community-based organizations to be part of this senior coalition, which ultimate goal is to promote decreasing of the burden of the disease and healthy aging, but increasing the readiness meant to sit down with each of these community-based organizations many times and then deciding how can we learn from each other. So it's not one person. To me, in our setting, it's at least 20 plus organizations. And the development of these activities so we can know each other on purpose, intentionally. It's not like, hey, I need you to recruit people. It's not like that. That is the absolutely worst message. It's like, let's work together. How can we improve? And so that was one, improving the readiness of the organizations. Each organization responds to certain group of people. And then together, how can we impact the local communities in rural areas like South Texas and in the cities that are in South Texas? So this takes several groups, not trying to do just one size of activities for everyone. So now we can say we have different groups of people that are working either in the Rio Grande Valley or San Antonio or, in the middle of nowhere with the farmers. So to me, the leadership needs to be distributed, needs to be supportive, and needs to be toward a common goal that is not just recruitment.
Love that. One of the things that we've been doing, and it's being led by Dr. Crystal Glover, is these series of design studios where she's been working with participants, community leaders, and researchers to try to figure out, what are their needs, what are their concerns, how can we address them, how can we provide materials to help educate those communities. And she's been doing a really wonderful job and actually helping our researchers also understand the importance of qualitative research. I want to put a kudos to her. The other thing I wanted to mention is that ORCOR staff are typically the people who are going out in the community, helping to try to educate them, trying to recruit them. But for me, I agree, it's not just about recruitment, it's about building that trust, it's about building those relationships. And one of the things our center has done is understood that it's not just I'm recruiting for this one study. I'm trying to build relationships for 5 to 10 to 20 studies. And so creating those collaborations, creating those partnerships, listening to those community leaders really makes a difference.
I have to say that one of the things, I have to agree with what each of them is saying. You have to listen to your community to find out what their needs are and figure out what you can contribute. I think it's also important to have things that indicate that you're not just there for the biospecimen. So in Georgia, with the leadership of our Alzheimer's Disease Research Center and our Department of Geriatrics, I was a part of the Department of Geriatrics before I became a part of the Department of Neurology, we have helped get people what they need. And you may want people to participate in your research studies, but we also don't want people in our research studies who are ill, haven't been diagnosed, haven't been this, haven't been that. And one of the ways you do that is to make access to healthcare possible. So our leadership has engaged with the state of Georgia to create something called the Georgia Memory Net, whereby people who are living in urban, metropolitan Atlanta, and rural areas around the state have access to a diagnosis of Alzheimer's or related dementia. We're partnering with the Alzheimer's Association and other people to develop those wraparound services. But the point I'm trying to make, unless somebody say, oh, everybody can't do that, everybody can do that if they want to. We had a lobbyist who helped us do that. But people of color, people who are in lower socioeconomic status, whatever ethnicity they are, have a need, a basic healthcare need. None of the researchers in here want an unmet medical need to be addressed as part of their research. Well, that's not us. You can't be in research. Go get that fixed. But where do you go get it fixed? So I think that when you start looking at other populations, understanding and identifying what their needs are is important and demonstrates some sense of commitment to whatever it is, whatever the community is that you're a part of. You cannot expect unhealthy people to participate in our research. You cannot expect people to walk up and say, I have MCI, or no, I have Lewy body. Who knows that? Okay, the average physician, the average primary care physician sees a patient every 15 minutes. How much time does 15 minutes take to identify MCI for those 100 MCI people you want in your observational study? You know, it takes a little bit more than just coming to us and asking us for a brain, a specimen, or something. So if you're going to demonstrate true commitment to the community, make sure that whatever resource you have that needs to be made available to those people is provided. I'm not saying you have to provide a doctor. We're working on something else, but I think that your existing healthcare networks can be better utilized to help promote better research participation by all groups of people. And you have to make use of the medical providers that are seeing your people, whether they're white, or they're brown, or they're black, or they're yellow.
In our center, during COVID, most of the participants were not able to be seen. Most of the participants needed things like PPE, and in Black and brown communities, they needed masks and hand sanitizer. And so we found a way to get that to them. We collaborated with other departments. We collaborated with some of our own faculty members who have relatives in China, was able to get us some masks. We were able to do all those kind of things. And the other thing I want to mention is we have found that our participants are getting older, and some of their needs are things like, how do I get a home maker to come in? How do I deal with my Social Security? How do I deal with all of those other basic things that we don't think about in relation to our research, but those are things that our participants need too.
Thank you. David, do you want to weigh in on this conversation?
I do. I want to emphasize that our community is also within the ADRC. You have experts. In my case, I have experts who have been hired, and they are members of the very communities that we are trying to serve, and empowering them with the tools to actually give first. I love Crystal Glover's work. Give first before you can ask for participation, and the responsibility that comes with participation, showing up every year, going and doing things that are scary. This is a lot of work, and you come in with an ask right off the bat. You can't do that. We have to empower our members of the community that are closest to us, help them understand why this is relevant, and have them go out with resources to engage community members in a meaningful way. So if that's connection with services, that's one skill set, but it's also things as simple as the PPE. These are tangible things that we can be giving to these community-based organizations who we're going in and giving the talks for, helping them find services, helping them provide services. So in my case, one of the things that we give back within the California Alzheimer's Disease Network is not only education and early diagnosis, but it's also things like our Healthy Aging series for these community organizations, the online series of The Good Life. These are meaningful givebacks that engender trust and put a meaning, more than just sort of like the abstraction of trust. It actually builds a bridge where you get to go and learn and have fellowship with these people and understand what their lived experience is, which is the only way that you're going to make your research relevant to them.
Thank you, David. So what I'm hearing, number one, we're talking about leadership from a moment ago, and all of these initiatives that we're talking about now required leadership to push it, to pull it out. And so it's just, these changes don't occur passively. It's got to someone has to take some responsibility. David, when you were talking earlier about, in your talk, what the leadership that's going to be required to do a cultural awareness overhaul in our centers is going to be key. And so I think it's just, maybe I'm going to leave us on that leadership note, that it will not happen all by itself. There's got to be leadership to effect change within the institution. So I'm going to leave it at that, because I think that's all very obvious to us, that we need to have that leadership to make a change. We've got a few minutes left, and what I thought we could do at the very end is to go around to each person, and I'd warned you all that we were going to ask, but Can you please each articulate a single action item? For our centers, we've got all centers represented here in the audience. What is your single action item that we can take on to make change in creating, fostering a more inclusive environment? And interpret that in any way you'd like. Dr. Maester, would you like to start?
Yeah, I think that one single thing, it's to include as core co-leaders, diverse and young investigators, early career investigators that are coming from very different backgrounds.
I think you should increase the budget for ORCOR leaders. we need more staff desperately. And if you want more diverse participants, having money to pay for your staff who represent those communities will make a difference.
I have to agree with everything everybody said. More money, more money, more money.
Not so fast. That's already been said. You have to pick something else, Dr. Parker.
I think, I just think that we have within all of our centers what I call missed opportunities. You know, you do have providers, you do have people who are interested. We need to do a little better job identifying the people who want to do something and making it possible, as Dr. Johnson said, giving them the resources and other things. We do have people within our centers that have the interest and the drive and some of the connection. I think it's nice to have younger people around, but I also think, and I guess this is the baby boomer in me, please don't overlook those of us who are a little older. You know, sometimes you're retired educators, you're retired something or others, have a lot to offer. And maybe they are volunteers, but you know, everybody doesn't want to work for free. But look at some of the older retired people in your orbit who are interested in doing this. A lot of our older volunteers come from, they're CEOs of other companies, and they have a lot of influence. I agree with the young people, but please don't overlook the older people.
And Dr. Johnson.
I'll probably, well, I think inclusion needs to be taken very seriously by the NIA and made it a topic within the RPPR, and leadership is held accountable for equity and inclusion issues, and that we need to report them. And there needs to be a sort of a sunshine policy towards surveying the climate of equity and inclusion within the ADRCs. And I think that that will be the first and most important step, where we have an equity and inclusion section on our RPPRs. There's a thoughtful set of standard surveys, and we publish and know what the policies that we have that are working and not working within the center network.
Okay, thank you. And I have one too. I'm not a panel, I'm not a speaker, but what I'm going to do is just reflect back what I've heard from everybody. And we said it, but I think it deserves to be repeated. And it feels to me one critical obstacle that maybe is slowing progress is that we haven't truly decided to date and marry our communities. To use your analogy, Dr. Maestra, we like them, we wave to them through the door, through the window, but we haven't decided that we actually want to date them. And I think to use that expression, and what that means is we have to make a decision that we want to invest in that relationship, that there's meaning and there's something in it for me, and there's something that I have that I can give back. And until we decide that we're ready to date our community and take the relationship further, I have to say we're never going to get anywhere. We're not going to make any progress. And many of you are all selected because you have made that investment in your community. So I'm just going to say that that would be a charge for our centers. It's a deep dive to figure out how do we invest more of our emotional and mental energy into the community, and so that we are willing to share the power. If we're not willing to share the power, we will be having the same conversation 10 years from now. So I think we'll, wait, so any questions from the audience? No. Okay, sorry, we ran out of time. That's for you, for the closing. Yes. I think we're going to close now, I'll say it first, and Dr. Parker can say it, express it too, but I've just been very honored to be on stage with 4 very fine, accomplished folks who think, breathe, sleep, inclusion, equity, in an effort to have representation in their cohorts, in their lives, in their staff, in their people, because it does enrich your lives. And that's why we do it as well. So I'm just very honored and thank you.
My job is to summarize, and I kind of had to submit my summarization before I actually got to this discussion. So next, oh, that's me. Okay. Recruitment and retention of underrepresented minorities requires an intentional, consistent, and demonstrable effort. Dedicated personnel must be assigned and focused on this task. You've heard that from each of us. We have to have respect for the humanity of minoritized communities, extend basic courtesies, refrain from patronizing behaviors. Establishing collaborative relationships with organized community groups serving targeted community will amplify our efforts, foster trust, and project success. Organizations should include nonprofits, faith organizations, advocacy organizations, fraternities, sororities. These are examples. Other community-based organizations do have service missions. Learn what they are, learn what they do in the community, and how we may assist them. Community outreach must address health interests, needs, and resources of the targeted population, i.e. things like health preservation and healthy aging, resounding themes, providing patient navigation for healthcare access and resources for supportive people, clarify and explain what the research is, what the research process is, and provide some accountability for our different research activities. Educational outreach approaches must be specifically tailored and engaging for older adults of different cultures and involve ongoing health and neurologic research. And with that, we close this session. Thank you. You've been a great audience.